while the others make their way forward.
Perfect. Good afternoon. Thank you, Madam Chair Colcourse, Vice Chair Perry, other members of the committee. For the record, my name is Dr. Kelsey Smith. I'm speaking on behalf of myself, as well as President of the Direct Primary Care Alliance. That is a national organization that represents direct primary care physicians nationwide. I'll be testifying on the interim charge before the committee, and thank you for inviting me here. I applaud you for taking on this massive challenge of trying to provide affordable health care in the state of Texas. The packet that you have of my slides, the second slide, kind of gives a little bit of my biography. I'm a board-certified family medicine physician. I've served my community in Stillwater, Oklahoma for 19 years. I began practicing there in a private insurance-based clinic, and my partners and I, we were the quintessential rural family doctors. We delivered babies, we saw our patients when they were in the hospital, and we had a busy clinic schedule on top of that. But over the years, I could see the writing on the wall as the corporatization of healthcare, like we've heard about all day long, threatened the existence of small practices. It forced us to increase the volume of daily visits, and to stay afloat, we eventually had to give up our hospital and obstetric care part of our practices. My partners continued in this model, and as a result, they often see 40 or more patients every day. But I chose to maintain my independence by extracting myself from the insurance-based model and transitioning to a direct primary care approach in 2021. My patients now pay a monthly membership fee. At my clinic, it's $100 for an adult patient, $50 for children, and a maximum of $350 per month for a family. For that fee, they can see me as many times as is necessary for no additional charge at the time of the visit. It's a model that can provide the majority of a patient's healthcare needs and restores simplicity to medicine in ways that I hope to partially illuminate to you all today. The next slide talks about first, do no harm. As physicians, this is a concept that we are taught from day one. It's ingrained in us, but direct primary care physicians expand that concept to include no financial harm. Because we realize many times even well-insured patients are foregoing needed medical care due to the cost. The next slide is kind of similar to the chart that you showed with all the complexity and middlemen that are in healthcare. There's a reason that the most expensive instrument in medicine is the physician's pen. When you look at how complex the system is with all the number of middlemen, doctors are in one tiny spot on the lower left in the slide you've got, and patients are kind of divided into a couple boxes on the right. The rest are all middlemen, whether they want to believe it or not. Because of
That was a sore subject in the last panel.
Because of the complexity, healthcare transactions are the only place where both parties involved in the transaction are blind to the cost. Doctors are told it's too complicated to know what everything they order costs, and truthfully, when you're working in that insurance-based model, it is. Patients are then told they must always use their insurance because healthcare is just too expensive to pay out of pocket for, when in reality, we all need to be asking questions about the costs. The next slide is much more simple. Direct primary care simplifies medicine back to its foundational relationship, simply between a physician and their patient. And the next slide shows someone at the grocery store. And if you can imagine going to buy your groceries without any prices on the shelves, and you don't get a bill until weeks later, while someone else negotiated on your behalf the cost of those groceries using contracts you were not allowed to see, that's essentially what healthcare is, and no functioning market operates that way. The next slide is a list of some costs that are from my family's lived experience. I started asking questions about the cost of healthcare 10 years ago when my own husband required sinus surgery. We had good insurance and assumed we'd go to our local hospital where one of my trusted colleagues would perform the surgery. And we then received a call from the hospital billing department who advised us the total cost of the surgery would be $30,000. They assured us as an insured patient, well, you won't pay nearly that amount. That's that imaginary charge master cost, right? But as a dual income professional family with a high deductible plan, even the calculated amount that would come out of pocket was untenable to us. So I told them no thank you and started looking elsewhere. That was when I started to really dig into cash pricing in medicine, and I discovered the Surgery Center of Oklahoma, which is just down the road from my hometown, and they provided that same surgery for under $10,000. I was surprised at that time. I've become a little more realistic now, but at that time I was surprised that the cost that we paid for out of our health savings account did not even apply to our deductible, as they argued that that location of care was out of network, even though the physicians involved in the care were in network. Ironically, in many, many cases, insurance does not reward patients for choosing lower cost options. And I would point out, all of those examples on the slide come from my family's lived experience. My husband's colonoscopy was free to us because it's a preventive service, but the charged amount to our health plan was $22,000, I believe. And the paid amount was much less than that, but it illustrates that point that the charge master charges are just out of control, not based in reality. My husband went to see an orthopedic surgeon for some shoulder pain, and it was a $1,200 cost for a single visit plus an x-ray. We got that negotiated down to a $460 cash price. And then my son needed CT scans on his feet, and that was going to be about $4,000, and we got it negotiated down to about $400 cash. The next slide talks about another area where the true cost was somewhat striking. After I switched to direct primary care, I started looking at the cost of prescription medications. And as many of the previous speakers mentioned, the PBMs and vertical integration of pharmacies are reducing competitions and definitely put small pharmacies out of business. No matter what the particulars of that are, it is actually happening. We've seen 3 pharmacies in my town alone go under. And in Oklahoma, physicians are permitted to dispense medications directly to patients. So one way I pushed back against this monopoly was to become a dispensing physician. In my office, I then stock a supply of generic medications at wholesale prices, direct from the manufacturer or the wholesalers, for many common ailments. And a lot of the examples for common medications I can get are in the slide that you guys have in your packet to highlight just a few. Amlodipine is a pretty common antihypertensive medication. I can dispense it for $1.60 for 100 tablets. And the retail cost, and that's at a GoodRx coupon price, is $11 for 90 tablets. Similarly, I can dispense a packet of birth control for $4 a pack, and the retail cost through GoodRx is about $30 a pack. The last example in that chart is for a generic asthma inhaler. There's an 88-year-old patient of mine with Medicare benefits who buys a standard asthma inhaler from me because it costs her $140 at the retail pharmacy. She's tickled that I can provide it to her for $75, but I'm still pretty disgusted that I can't get a generic asthma inhaler that's been on the market for a couple decades for under $75 a month. That just seems ludicrous. The next slide, we've talked about different ways to disrupt and maybe scale this model. I contract directly with several local but small businesses that have under 50 employees so that they don't have to supply insurance to them, but they want to provide benefits. So they might pay their direct primary care membership so they at least have a primary care physician that they can get the majority of their care from. We contract with a local plumbing company, heat and air company, an oil well service company. It's also been adopted by larger employers and even some forward-thinking insurance companies. Mending Health is one company that I work with in Oklahoma. It's the only insurance company I partner with. They pay for direct primary care membership for all of their covered lives with an insurance company that covers services required outside of that. These patients don't have to take advantage of their DPC benefits, but many of them do. And what they found was a 36% lower overall medical costs in the DPC patient group, despite those patients being older and higher risk. And even after the DPC membership fees were paid, over $25 million was saved across all their members and their networks in Maine and Oklahoma between 2024 and 2025. In the last slide, there's several ways you can help to improve affordability and restore competition within healthcare. You can preserve and expand direct primary care protections that allow patients and physicians to contract directly with one another, allowing for transparent pricing and fewer administrative barriers. Support health savings account flexibility, including utilization of HSAs in your state-sponsored plans. Strengthen meaningful price transparency. Practically everyone here today has talked about that. But both patients and physicians should be able to easily understand the cost before receiving care and not weeks afterward. Fourth, increased scrutiny of pharmacy benefit manager practices and pricing structure, particularly where vertical integration is happening. It's limiting competition, pharmacy access, and increasing patient costs. And lastly, consider whether direct physician dispensing could improve medication access and lower prices. In summary, understand the current healthcare system rewards complexity and consolidation rather than transparency and affordability. It's failing the physicians and the patients that depend upon it, and healthcare becomes dramatically more affordable when patients and physicians can actually see prices when making treatment decisions and are allowed to provide care without the interference of layers of middlemen. Thank you.
Thank you, Dr. Smith. If you need to leave, you can. Does anybody?
I
You
can
okay?
stay for questions.
Okay. Mr. Lynch.